thank you all for being here. And again, no bios. They're all in your booklets. David Brager, I've just met him in preparing for this and was connected with him to be on my planning committee, which was great, and thank you very much for putting your name on that. Joan Papp also was technically on my planning committee. I feel like Joan is sort of the backbone of the whole process. There was a question about Project Dawn and about getting Narcan into the hands. For all of you that were here most of the day and this morning and heard them talking about how many deaths there were in your reports in your booklet, and I know right now the number nationally is something like 70,000 people a year are dying. I just want to say that imagine what that number would be if we didn't have Joan Papp handing out Narcan and developing Project Dawn in this area. God knows where our death count would be. So thank you so much for all you do. David Streem, I also was just recently connected with him in relation to the hospital consortium. I don't know how much of you even know about that. It's sort of, I feel like it's not talked about enough that, you know, very often the hospitals fight, right? We're number one, we're number two, we're number three, and everyone wants that higher spot. In this case, with opioids, this is an issue that has finally brought these best rated hospitals, nationally rated hospitals in Cleveland together to work together finally and really develop good plans on moving forward and what's needed in this epidemic. So thank you, Dr. Streem. I appreciate it. And Christine Antenucci, I've known Chris for years. She also knew my daughter years ago when she was basically a little girl. I mean, I don't know if you'd seen her since she was like 10, but you did know her. And as she played with kids on the floor, because that's where she always was. And thank you. Thank you for what you do. And I'm anxious to hear about your change that you have gone through professionally due to this epidemic and helping people. So with that, let's get started and go for it, guys. Thank you.
Good afternoon, folks. My name is Dave Brager. I'm a nurse practitioner at Center for Families and Children / Circle Health. I know it's in the bio. Circle Health isn't. I have been a nurse since 1989. And I have been indirectly or directly working in addiction medicine that entire span. It's been the last 15 years that I've been working in the advanced practice role. And in the last 5 years that I've really been introduced to harm reduction and really actively involved in harm reduction. I am to a question answerer like Andy was, and what I start with is what was the most significant thing that's occurred in the last 5 years for me. To say that there's been a lot of pieces and parts that have brought me up to that, because I really believe that. Because I've been in the recovery community for about a little over 35 years, and that had brought me to nursing, and that had brought me to working in the active field of addiction. And as a byproduct of that, I'm a true abstinence model person, and I learned that from a very rigid place. And for me, the challenge and the change that occurred in the last 5 years was to be swung from a pure abstinence model person to a harm reduction / client-centered care person. And for me, that was a real process of learning, not only in my professional life, my personal life, and all those things. It kind of started with, you know, some of my heroes are here. Dr. Perrin, someone that's on the committee is Dr. Delis Reyes, Dr. Bailett, because I got to hang out with those babies at the high-risk pregnancy unit, and all those things have led me to be here in front of you today. You know, what helped me on my way was, in fact, the Addiction Fellowship and being introduced to Dr. Delis Reyes, because she is truly a harm reduction person. And I love that she calls it now client-centered care. And that's the model that I live by, and it's the model that I've sort of lived by as a psychiatric mental health nurse practitioner. I've been dealing with dual diagnosis my entire career as an advanced practice nurse. I relish that. It's the people it's my people, you know, it's who I like to work with. And when it came an opportunity to become a part of the Addiction Fellowship, I was all about that. And it was an opportunity for me to be introduced to a lot of people, and it set my feet on the ground of working in opiate addiction. In my recovery community, I've watched people die as a result of opiate dependence. I've gone to funerals. I've joked with one of the members that I sponsor. He has to quit sponsoring those opiate addicts because I don't want to go to any more funerals. It's a joke, but it's not a joke. It's a very serious statement. That in and of itself has been one of my best lessons in learning the process of going from abstinence model to harm reduction model. I knew a young man, and I'll briefly tell his story. He was in program, and he was staying clean and sober. And his significant other and he had a child together. And they relapsed together and both died. And this was in Mentor. Probably was in the paper, probably people know about it. I know about this 3-month-old baby that no longer had a mom and no longer had a dad, and grandma and the other grandma were going to at some point have to be able to tell that little girl about what happened to mommy and daddy because of the disease of addiction and the disease of opiate dependence. This is a disease that kills. It's been said through so many different people in so many different ways here today, and I feel like I have just some small gem to give in parts of that is that this is a chronic relapsing brain disease. People don't choose it. They are affected by it. They are not the addiction themselves. They are a person suffering from the disease of addiction. And we are about the responsibility of helping them take care of that. And what a privilege and an honor it is today. A part of me, I do this work, and I work with a lot of opiate addicts, and I see some of them get better and some of them not. And I have worked in the field of addiction, and I see some of them get better and some of them not. But I see all these people here today that really care about people in recovery and people in addiction that are trying to survive. And when we remember that it's that survival salience that Dr. Labor was referring to, that survival factor, that the substance becomes that important, that it's about survival, then we start to take a look at, why are, and this all sort of led me to opiate addicted pregnant women. And part of being in the Addiction Fellowship is that Dr. Delos Reyes was no longer going to be a part of the MOMS program because the grant ended and all that political crap that occurs. And so she's like, well, why don't you do it? And so I'm kind of like, Mikey, why don't you do it? So I'm pretty open-ended, and I like to listen to the people that are my mentors. And so I tried it. And it was never a part of my plan to work with opiate-addicted pregnant women. It was never part of my plan. That was never going to be on my, resume. But one of the best things as a byproduct of switching from abstinence model to harm reduction is that I got to work with those moms. And I still treat about 15 of them. They continue to be on Suboxone. Out of the 17 that I was seeing, 15 of them still have custody of their children. Some of them work full-time jobs. I get to hold babies on occasion, which is completely one of my favorite things to do. And I'm one of those weird people that Dr. Labor was talking about. I get dopamine level increases by getting to hang out with babies and kids. And, I don't have children in my life, so God's got a sense of humor, and we do what we do. And how passionate it is, because you know what? They do recover, too. We can get the babies and the kids support. I've been with these moms long enough that some of them, their kids are 2 and 3 years so old. And they continue to come to me, continue to be clean. Some of them have bumps on the road, but all of them have survived from this disease. And to me, that helps me to be okay with the harm reduction model, because you know what, they're not dying. And that's why I show up for work on a daily basis, because I get the privilege of hanging out with these folks, and I get the privilege of offering someone the opportunity to change their life. Not perfectly, but it works. And it's a privilege and an honor to see them get clean and sober. And it continues to be something that I will continue to do until I'm done doing this work. Because it's kind of like, I kind of feel like higher power, I believe in all that stuff too, and recovery stuff, but, it really talks about we get directed, there's a direct flow of existence to why we do what we do. And I have compassion for it in so many ways because of that stuff. And what a privilege and an honor to see people get better. What a privilege and an honor to see these babies get through neonatal abstinence syndrome and be okay, And we need to be here for the next generation because they're coming. They're coming, and this disease is not going to go away. So many people have said the same things, and I tend to bring in other people's stuff. But, at first it was cocaine in the early 90s. Now it's opiates. Now it's going to and methamphetamine is on a rise. And it's just like we have this surge of addiction that isn't going to go away anytime in my lifetime. And I will continue to do this work because I know that these people won't go away, sadly. I would love to see every addict and every alcoholic be done with the disease. The reality is that's delusional today, and I know that the disease doesn't change. And, it runs in families, and I'm a genetic model person that believes in the genetic process. It says, what's the most pressing issue? It's been said about 15 times in different ways, the stigma that's attached to the disease of addiction. And I work in community mental health, so on top of it, if you have a dual diagnosis, and many of the people that I work with have dual diagnosis, they have not only the stigma of addiction, but the stigma of mental health. And here we are today at a time when treatment is available. And slowly, gradually, every person in this room can have an influence on what we do each day. And then the final question was, what do you see as missing? And I think that organizations tend to be silos, and I think that's a problem. I think we as a group need to work together. That without you and each person in this room, there might be another person that dies today, and it will happen. So we need to work together as a community. And that community can be the legal system, that community can be professionals, that community can be the people in a program, that community, whoever it is, ministers, employers, whoever we can get involved. There used to be a time that EAPs were involved in people getting into treatment, and you used to hear about it all the time. You don't hear about it so much anymore. The bottom line to it is we need to all be involved. And I think that the final piece, and I don't know if I'm being brief and short, and that's what I'm going to say, but my final thought is that, one of my favorite stories is the starfish story. And there's a little boy that's walking along the beach, and there's hundreds and hundreds of starfish along the beach. And he's throwing all the starfish he can get back in the ocean because he wants to save them. And this old man walks up to him, and it's kind of, I have a different version of the story, so bear with me. The old man walks up to him and says, "Boy, what are you doing?" And he said, "You're not going to save all these starfish." And the little boy holds up the starfish, and he said, "It matters to this one." And I think that connection, that sense of community that's in this room today, if we can all hold up starfishes and we can all be that example and save a life, we're movement of change. We're in action, or whatever. We're enabling change. We're a process. We're a part of the change. So if we're a part of the solution, I know we're not going to be perfectly a part of that solution, but you know what? I think each of us wouldn't have been here today if we didn't care about these folks that are suffering from this diseases, because the disease of addiction is killing people. And as was said, it's only been in the last, 15 years that we really when it got into the suburban communities that we started to get treatment out there. But people have been dying from heroin addiction a long time ago. It's finally that we're starting to take some action. And we as a group need to work together. So I'm all about the sense of community, because it does take a community to raise a child, but it takes a community to raise a drunk and an addict. Thank you.
My name is Joan Papp. I am an emergency physician in Metro Health, and like the other folks that have spoken and are on this panel as well, I didn't really start off thinking that addiction was something that I would spend or dedicate my entire career to. I've been a practicing emergency physician at Metro Health since 2000. And around 2012, we really started to see a big change in our emergency department. We started seeing people who using opioids, and we started to see a shift toward heroin. And, unfortunately, I also, like many of you in the audience, had an experience in my own family. A close family member became addicted, and it really changed my perspective. It was no longer them and us. It was all of us together. And this was a problem that I knew as an emergency physician, I was in a unique position to change. And so I started with what I know best, and that's naloxone. We use naloxone in the emergency department all the time, and wanted to find a way to get naloxone or Narcan out into the community in ways that would make it more accessible and available for people who were using opioids to save their life. And did a little research on programs across the country and found that a new program was starting in Ohio, down in southern Ohio, and reached out to them and asked if they would let us bring that up to Cuyahoga County. That program's Project Dawn. It's deaths avoided with naloxone. We started that in 2013. And really kind of exploded. We got a lot of support and were able to get Narcan out not only in the community setting. We have 5 walk-in sites across the county now. I know there were some questions earlier about that and where to get it. So Monday through Friday, we're at the Cleveland EMS headquarters. And on Friday mornings, we are at the Board of Health in Parma. Friday afternoons, we're at Circle Health. We're also at Circle Health on Tuesdays. And for a detailed list of all of our hours, just check out our website at Metro Health under the Office of Opioid Safety, and you can get all those hours. Narcan's also available in pharmacies across the county as well. So CVS and Drug Mart, Giant Eagle Pharmacy, I'm aware of their standing order as well. Keep in mind you'll have to pay for it if you do go to one of the pharmacists. If you go to one of our walk-in sites, it is free. But we recognized after running Project Dawn for a few years that we really needed to take a little bit more of a comprehensive approach. Narcan was important to be first. That was sort of the emergency response. That was, I kind of think of that as, just kind of putting your finger in the dike, right? There's all this flood of water coming, and I've got to do something. I've got to save these people's life. That was sort of the first piece. The next part, in taking a comprehensive approach, was looking at what could we do to reduce harm further and what could we do to treat people. And I don't have any formal training in addiction medicine. I am an emergency physician and sort of sought some advice from our colleagues and the experts on our task force and our consortium, and we developed a number of programs in our hospital system to address the crisis with medication-assisted treatment. We developed a program in our emergency department to initiate MAT right from the emergency department and then connect those individuals with a peer supporter and then directly transport them to a treatment program if they're ready and willing to do that. We started that program in 2017, and we have peer supporters now. Those are folks who are in recovery, who are working with patients to motivate them, encourage them to change, and then really sort of hold their hand and make sure that they get to that next step. Oftentimes, they will even travel with them in an Uber or a Lyft and take them to the place that they need to go and do that warm handoff. So that's been one of the most significant services that we've been able to offer our patients at Metro. Those peer supporters are available not only in our emergency department, but also throughout the hospital and in our county jail. Chris told me that earlier today there was a panel talking about the jail and the lack of services there, and I think they should have known better. We absolutely offer services in the jail. In fact, our hospital has the contract to provide health care, and we were prior to the beginning of this year, we didn't have the full contract, so we didn't have the nursing support. Those were still run by the county, but now every aspect of healthcare in the county jail is supported by Metro Health. They're all Metro Health employees, which makes all of the inmates in Cuyahoga County Jail Metro Health patients. And we have a actually quite robust addiction treatment program there. It started off with a small grant to provide an alternative to incarceration program for a select group of inmates who would qualify for this based on their charges. And we've grown this to essentially a medication-assisted treatment program for inmates that are appropriate for medication-assisted treatment. We still work with the judges in the courts to offer and to help the inmates secure an alternative to incarceration sentence, because we know that treatment is the only way to recover. Going to jail and going to prison is not going to cure the disease of addiction. And so we have, in our program, we have 2 forensic coordinators, one that works directly with the courts, goes to court, advocates for them. We have another forensic coordinator that helps to connect our inmates with treatment after they're released. And we have, inside the jail, we have 2 chemical dependency counselors that do the assessments, provide behavioral treatments, and any of the other sort of referrals to treatment that are needed. We also have a nurse practitioner who's dedicated to providing medication-assisted treatment. That's the only thing that he does. So we do Vivitrol, which is long-acting injectable naltrexone, and we do buprenorphine. And we just recently received funding from the multi-district litigation as part of the county's award to us to start an OTP, or an opioid treatment program. So we'll be able to continue methadone for inmates who come in on methadone. So we're really excited about that. We hope to have that up and running before, I don't want to say the end of this year, but sometime next year. That's our goal. So our goal is to make all 3 forms of MAT available to inmates in the county jail. We also connect those inmates with peer supporters as well. And they receive that peer support in the jail, and then once they're released, they're connected to a peer supporter out in the community. So, what other things need to be improved? I think getting MAT out to all parts of the community in a low threshold access is essentially where I think we need to go. Currently, getting into medication-assisted treatment is a lengthy process, and oftentimes you hear, okay, we want you to come in, get your assessment, and then you can come back a week later, and then you can get your medicine. Well, unfortunately, for a lot of people, waiting a week is just simply too long. And when we started in the emergency department, we're only by law allowed to give them 1 week's supply for induction. And so oftentimes it can be a challenge to get them to that next appointment in time before they run out of their medication. And so, I think that's the most important thing that we need to address, making sure that medication-assisted treatment is available not just in addiction clinics. It should be available in emergency departments across the county. It should be available in primary care, and it should be available in other specialty clinics. And Chris, I know, is going to talk a little bit about primary care. She has been a leader in our hospital, bringing MAT to the family practice department. And so with that, I'm going to hand off to one of the real addiction specialists.
So thank you, Joan and David. So my name is Dave Streem. I'm a psychiatrist, and my day job is I run the drug treatment program at Cleveland Clinic, and one of my other hats is as chair of the Northeast Ohio Hospital Consortium, which is really a great organization that helps coordinate and share best practices for all of the member hospitals and organizations that make up the consortium. So one of the things that's helped facilitate in the last few years, along with some changes in the state and federal regulatory levels, is the proliferation of information. Information, as Ted said earlier, about the difference between secrets and privacy. So when physicians and healthcare workers and probation officers and recovery court judges and all the social workers, case managers, when all of us have access to all the information we need, then we're really in a position to do right by the patients. But as probably everyone in this room knows, that's not something that always patients are interested in sharing. So it's really incumbent upon us to have access to that information, whether the patients want to give it or not. And again, this is all about using that in the patient's best interest and to improve those patients' chances of doing well. So it's about being positive and about having a mindset of beneficence, which obviously is why all of us come into work every morning, is to try to do right by patients. So that information sharing of best practices, sharing of different techniques for using information, and then also developing best practices as far as opiate prescribing. So I work, most of my day for Cleveland Clinic, and of course the clinic does a lot of surgeries and procedures, and many of those do involve people going home with prescriptions for opiates. What's interesting to me in the last few years is how much we've been able to reduce the amount of opiates that patients are exposed to in the OR, and also reduce the amount of opiates that people go home with. And we've also, I think, done a nice job, not just within the clinic, but within the city, of improving the care that folks, IV drug users who develop heart infections and need valve replacement surgery, and then usually 6 to 8 weeks of IV antibiotics, how well we support those folks in terms of linking them to addiction treatment. And that's been a really nice part of my work. Just one other thing I wanted to mention that piggybacks on something that Joan said is she mentioned how much support there is in the jail, and she and I also happen to know that there's also a very excellent psychiatrist who used to work in my group and then went to work for Metro because he does have a very passionate interest in improving the conditions in the jail. And I worked with him for 6-7 years, and he is just a great psychiatrist and a great asset to that group that Metro has put together to service and meet the needs of the folks in the Cuyahoga County Jail. The most pressing thing that I want to try to work towards changing is improving the acceptability of medication-assisted treatment. A lot of us have mentioned that. I think there's a nexus of problems there, and we've all kind of touched a little bit on one part of the elephant. There's been some operational issues, particularly in sober living. How do we that I'm sensitive to? How do we store a medication that does have a street value and that is potentially, abusable, I guess? So how do we do that? And of course, the answer coming from the addiction provider is there are injectable forms. So we don't have to store it. We don't have to administer it every day. And that creates the next problem, which is who's going to pay for the injectable forms as opposed to the sublingual forms. And then we get into the insurance and the insurability and how much, expense it is worth making best practice treatment available to this patient population. And that's also another factor that's important in the jail and in the prison settings, is those sorts of non-sublingual, non-pill form treatments are really nice options. So making those treatments available to people most in need is I think a challenge and a problem that has not been solved yet. And then lastly, I just wanted to mention about things that we really need to work on in the future is things like, and again, in the last panel and in previous panels also, we've touched on this, is the issue of privacy and relating the HIPAA rules, which are one thing, to CFR 42 Part 2, which is the privacy rules that predate HIPAA that involve privacy related to substance use records produced by people who primarily hold themselves out as treatment or providers of addiction services. So just a quick way to get the tempo of the room here, the sense of the room here. How many of y'all are covered Part 2, CFR 42 Part 2 providers? And if you are, you know it, and if you're not, you probably don't know what I'm talking about. But okay, so there's a few, but not a ton. Okay, so I run the drug treatment program at the clinic. For those of you who aren't familiar with this lovely piece of legislation, let me just explain this very quickly. So I run a drug treatment program, so I hold myself out primarily to be a provider of addiction treatment services. So I'm a Part 2 covered provider. So if you're a family doc, a neurologist, a pain management person, anyone who, regardless of what your training and credentials are, that you don't primarily hold yourself out as a provider of addiction treatment services, you can document anything in the medical record about a person's addiction history, about their drug use or alcohol history in the chart. Other folks will see it. It will be no more or less private than their sexually transmitted disease history, their smoking history, their cancer history, and so on. I am one of the few people at Cleveland Clinic, for example, that I can read things that others have documented about that drug history, but I can't document anything that identifies a patient as having a substance use disorder in the medical record. Even though that's what I do for a living, I'm the only one in the organization, basically, who can't document that, and everyone else can. And that seems, at the very least, not right, if not very counterproductive for a large health, wellness-based, medical, treatment and wellness system, a healthcare system. And that's not to mention our interactions with patients, which often involve all the other health systems and hospital systems in Greater Cleveland. So when we want to communicate with our colleagues elsewhere, 42 CFR Part 2 applies. So I'd really like to see that basically eliminated, and just the same privacy rules that apply to everyone else regarding HIPAA apply to me. And that would, I think, again, coming back to the importance of information and everyone being on the same page, I think that would really make a big change in helping our patients get the expert care and the best practice care that they need. And then lastly, the big issue that we've all mentioned a lot is stigma, and stigma. And there are a lot of organizations, there's some national organizations that really make that their priority to address, and obviously settings like this, the actions of advocacy organizations are really, really important to eliminating that stigma and addressing it. And that's going to get people into treatment sooner and help them to be more successful in their treatment. So that's really something more than anything when I come into work every day. That's one of the things in my mind is there something I can do today to really address that, both when it comes to patients, families, and also, let's face it, members of our healthcare systems, because that's a big part of the stigma problem is people who work in healthcare, whether they be in the emergency room, in drug treatment centers, in primary care settings, in surgical ORs, in administrative suites. All of that is something that we, it's really important that that we stand up and be counted for that. And it's definitely saying something stigmatizing in the middle of some sort of quality improvement or safety meeting that I'm in is a great way for me to end the meeting very quickly. And even though sometimes I feel bad about that, it's really important that we call that out instantly and let people in the organization know that that's not okay. And I think that's the only way that that sort of thing changes. So with that, I'll finish up my comments. Thanks.
So I'm a family medicine physician at Metro Health. I've been there for 20 years. And when I first started working in the world of family medicine, addiction, you had silos much more than you do today, where you had your behavioral health and you had your primary care. And addiction treatment lived in the world of behavioral health, which, as we all know, isn't how patients work, right? So you have patients in primary care who have addiction who aren't in the behavioral health setting. So over the past 5 years, I've gotten more interested in doing integrated behavioral health and primary care and done a lot of work around that. And that's led me to working with Joan on the Opiate Task Force and Jennifer Bailett on the Moms Clinic, and starting a primary care clinic at Recovery Resources where we can sort of integrate, and actually gotten me more and more interested to the point where I'm getting my addiction medicine training, hopefully. So the systems have gotten more blurred with time, but there's still a lot more integration that needs to happen. I think in the past 5 years, the biggest changes I've seen in primary care, I kind of put things into buckets, is prevention in terms of less opiate prescribing. And I don't even think, as Joan was going through all the different initiatives she's done, I don't even know that she really mentioned much about what she's done at Metro with the Opiate Task Force around reducing prescribing throughout the system and all sorts of tools in the electronic medical record to help right-size prescriptions and prevent over-prescribing. The other thing that's happening more in primary care at Metro is we've started a screening program, an expert program in our main family medicine clinic. And bit by bit, as Jessica said, it's really hard, but we've been trying to get primary care providers to actually offer treatment in their clinics. Prevention is key. So as I said, 45% of opiate prescriptions come from primary care providers, which is kind of humbling / embarrassing number. But the good news is since 2016, those numbers are down. The overall rates of prescribing are down. The other piece that I think comes into prevention is really, primary care docs like family medicine, med peds, and pediatrics taking the time in those well child checks to actually, check in about whether or not the teens or kids are engaging in high-risk behavior, talking to the parents about safe storage of their opiates and risks. As you all probably know, most teens that are using, or when they use, get their prescriptions from friends and family. So, trying to encourage other providers at our hospital in the primary care setting to do universal precautions when it comes to prescribing. Not going to really talk much about SBIRT because it's already been done, but we have started doing it at Metro. And there's at the very bottom, SAMHSA has a wonderful, is anybody here in primary care? All right. So if for some reason you want to start, hopefully, doing more integrated medicine in primary care, SAMHSA has a wonderful website with all sorts of tools for that. There's been tons of talk about MAT. So to just take a step back, the definition of MAT is medication-assisted treatment, and it is a term we use I don't know why we don't use it. We don't talk about insulin being medication-assisted treatment for diabetes, but we apply it to substance use disorders. So we have MAT, medication-assisted treatment for alcohol. We have it for cigarettes, and we have it for opiates. Unfortunately, we don't really have good MAT for cocaine or other things, which makes me nervous with the epidemic changing. What I will say, though, about MAT is, it's the standard of care. There's tons of good evidence that people have much better outcomes when, it's not one size fits all. Some people, abstinence is right for them. But for a large majority of patients with opiate use disorder, one of these 3 treatments has been shown to have really improved outcomes in terms of, their health, their mortality, not getting Hep C, not getting HIV, the chance that they're not going to have criminal activity, the chance that they're going to be employed. And methadone has actually got the most evidence behind it. Buprenorphine and naltrexone are pretty equal in terms of their outcomes. The trick is with naltrexone, people have to be sober about 7 to 10 days before you start it. So in incarcerated settings or a controlled environment, that can often work where you've detoxed somebody and you can sort of help them stay sober or clean until you start it. But in an uncontrolled environment, in the real world, in my clinic, it's very, very hard for most of my patients to go from actively using an opiate to not using anything for 7 to 10 days. So most of my patients are either sort of looking at buprenorphine or methadone. Methadone's hard to get in Cleveland. There's not very many clinics. Luckily, Joan is going to be spearheading getting some more access to more people. As a primary care provider, the only 2 options you really have, though, are the naltrexone and the buprenorphine. To do the methadone, you have to be in what's called an OTP or opiate treatment program. So again, it's just trying to, one of the big things I've been doing over the past 5 years is really trying to help spread the message just that it's not switching one drug for another drug. It's an FDA-approved medication for a chronic illness, and there's tons of evidence-based research that shows that it's very effective. The number needed to treat to save a life is about 4 to 5 patients. So as a primary care provider, there's not much you can do that gives you that kind of a return. And then one of the reasons I really push to try to get MAT into primary care, first of all, there are not enough addiction psychiatrists. There's not enough addiction specialists. PCPs are more likely to run into patients, right? That's who you see. And patients find that there's less stigma when they go to get care for their addiction from their primary care specialist. And for the primary care doc, if you're struggling to control someone's diabetes and they've got an active substance use disorder, you're really not going to get very far until you've sort of helped them start to get into recovery. I feel like it's often like about 6 months in where my patients start to say, oh, I haven't had a Papp smear. What about that colonoscopy? So, the MAT not only helps their addiction, but it helps their overall health care. And then to get to Jessica's question, most patients with opiate use disorder don't get treatment. The large majority of providers in the United States don't have their X waiver. So the X waiver, for those of you that don't know, or maybe all of you know, you have to go through, if you're a physician, you have to go through an 8-hour course. If you're a nurse practitioner, you have to go through a 24-hour, sorry. For some reason, as a PA or a nurse practitioner, you need that extra 16 hours. And then once you've got it for life. You've got your X waiver and you just periodically have to do some CME. But 95% of providers don't have their X waiver, and of the providers who have their X waiver, most don't use it. And then, which leads to the outcome where, there's lots of cash clinics in Ohio, right? So, and I'm sure you're all familiar with that, where you'll use your insurance to fill your buprenorphine prescription, but to actually get the buprenorphine prescription, some of my patients before they came to me would pay like $200 a week or $200 every other week to get their buprenorphine. all that being said, so it's frustrating. You have a very lethal illness like opiate use disorder where MAT is super effective, but people can't get access to it, and it's frustrating to me, which is one of the reasons that led me into doing addiction work. That being said, as a PCP, I totally get why people are hesitant to get involved in doing MAT, particularly in primary care. One of the things everybody's talked about is stigma. The other thing is lack of knowledge. Like Dr. Perrin said, I think in my medical school I had 4 hours of training on all of addiction. So, and then the other thing is fear. Like just the other day, I was talking to this wonderful psychiatric nurse practitioner, and she was asking me about her patient with heroin. And I was like, get your X waiver. You can give him his buprenorphine. And she's like, oh, I don't want to do that. If I do that, then they're all going to start coming to me. And so it's sort of, which is a statement that, again, a very well-meaning, very compassionate person, but it's this combination of stigma around, they're going to all come to me, but it's also fear of being the only doc and being sort of overwhelmed. There's also fear of, the DEA audit or, the 42 CFR, and what if I'm not in compliance? So part of, I think, again, I'm a bucket person. So when it comes to barriers to primary care, MAT, I think the first 3 are in the bucket of sort of information. Like PCPs need information about, opiate use disorder. And then I think the other bucket is infrastructure. Like PCPs, like somebody was saying, Jessica, I think you get 10 minutes with your provider, right? And as a PCP, you've got to deal with I think an average of about 15 things per visit, right? There's their rash and their birth control and their colonoscopy and their mammogram and whatever. So there's a lack of time. PCPs are burned out. There's often a lack of clinical support. If you're lucky in your clinic, you might have a team working with you. If you're most PCPs have maybe a half of an MTA working with them. So, and then there's this sort of siloed system where it's still a struggle if you're a PCP to in real time get the infrastructure to kind of collaborate and coordinate care with an outside agency. I use this slide when I'm working with primary care docs to try to talk to them. It's from the New England Journal of Medicine last year, and it just kind of goes over sort of reasons why PCPs aren't doing buprenorphine. And again, I'm saying buprenorphine because in the real world, if you're not at a methadone OTP and you don't have people in a controlled environment who can get sober for 7 to 10 days, then buprenorphine is the main tool in your toolbox. So again, it's safe, it's the standard of care, it's not hard to do. And the other big education piece we're working on at Metro is getting an inpatient consult service up and going around addiction, and also getting a fellowship up and going. So, some of the solutions besides trying to educate and provide information to primary care providers that we've been working on is also trying to sort of create more infrastructure sort of in the clinic to help PCPs feel comfortable doing it. I mean, there already is in some clinics, depending where you work, PCMH, which is patient-centered medical home, and CDSM, which is chronic disease self-management. So there's already these great models out there in primary care where we can address chronic diseases like diabetes or like CHF. And if you can harness those, that same care coordinator in the registry and your pyramid of team care, then you can plug addiction into that and sort of use existing infrastructure in your clinic to try and address addiction in a primary care setting, which is some of the things we're trying to do at Metro. But it's hard. It's hard to transform a practice. It takes a lot of time. And if you're interested in doing that, I put up a couple good resources of if in your clinic you want to actually try to start embedding care, taking it out of just like the individual provider's clinic to more of a system level. Vermont has a great model where they sort of created the hub and the spoke, where you had your treatment hubs and your primary care or community care spokes, and people that were really in the acute phases of treatment were at the hub, and people who were more stable were at the spoke. And part of my wish list is I would love to see a model like that in Ohio. Obviously Vermont is it's like 500,000 for the whole state, so it's like Cleveland. So I'd love to see a system like that in Cleveland, and we're sort of trying to work on that again at Metro. But that's probably the answer to the question of what am I hoping to have happen in the coming year. And then what else is missing is my slide. Oh, there it is. So, this is down, Sean Ryan, who I'm sure lots of you know about. He was an ED doc. Now I believe he's an addiction specialist. He was the past president of Ohio Society of Addiction Medicine. And he helped pilot in Cincinnati in 2017 a collaborative effort, which has a lot of what we're already doing here in Cuyahoga County. There was a collaborative committee that sort of involved the health department and the health systems and treatment facilities coming together and working together. And then they kind of had they implemented a two-prong approach where they got Narcan out into, the schools, the jails, the library, the faith organizations. But the piece that they did that I don't think we're really doing here that I really liked is they sort of have a 24/7 hotline where it's sort of shared information and they kind of do intake through that 24/7 hotline. And I know we have 211, which is valuable for giving people resources, but I would love to take that, my 5-year wish list, or was that the third question, is take that a step further and see, the 211 actually morph into like a 24/7 hotline where a provider or a patient or a provider and a patient together in a room can just pick up the phone and, initiate that intake process. So.
With that, I'll say thank you to this panel and big round of applause. It was a lot of information. Questions?
Yeah, I'm kind of focusing on the data analytics here. Since 2015, there's been so many deaths from opiates. Of those, how many deaths there were from opiates? Is there any identification of how many of those deaths were psychiatric patients for mental illness treatments? Has anybody looked at that?
The short answer is I don't know off the top of my head. I don't know if anyone else. Of course, there are correlates between people with substance use disorder very often have dual diagnosis, and properly identifying and treating people with coexisting psychiatric problems is, really, really important. It goes without saying. So why did I just say it? But anyway, so I think the short answer is that, of course, your question implies that it is very common, and it is. What I'm interested in is to what extent have those psychiatric problems, would they have been present but for the development of the addiction problem? And that obviously is a very difficult question to answer. A lot of, particularly my folks who have PTSD, have experienced the traumas that they've experienced because they've been using and have been around, people who are drug using or otherwise impaired from alcohol or drugs themselves. So if they've never developed the addiction problem, they probably wouldn't have been in that environment in the first place, never would have experienced a trauma, and then never would have experienced PTSD type symptoms. So I think it's a question, at least for me. I get deep into the weeds of that really quickly, and I think that's what makes it such a hard question to answer.
I'd also like to respond. I think that I can't quote you a number either, but what I do know is that a large portion of the population that I work with in a community mental health setting, huge numbers, probably 1 in 2 have addiction issues, hidden addiction issues versus the ones that we know about. So we may be at first treating a mental health diagnosis, but later to get a drug screen to see that they're glowing for something. And, there's pockets within the organization that I work in where the downtown offices are really hit more by crack cocaine, whereas versus the West office, which I work in, which is over near Fairview Hospital, there's way more heroin addiction, and it's over there. But I think it's rampant throughout, and I think it's interspersed. And I think from a historical perspective, even one of the co-founders of Alcoholics Anonymous had severe depression, and at that time in 1935, he wasn't treated because there wasn't much treatment available. And I think that all along we've had dual diagnosis as an active part of our addiction. And was it caused? Were the mental health issues there before? It's kind of like the chicken versus the egg. Was the mental health issues there before, or was the addiction there first? And you could get into this whole thing about poverty, because most of the people that we see come from a level of poverty. And is that a reason for mental health? And I think the fact is that mental health diagnoses and being on disability, they're poverty clients, many of them. And I think same thing for many of the addiction people, although that's not rigid in any rule. And I think just the two are like very married. And anyone that's worked in the field, or at least my experience in working with the field and working in detox centers and that sort of thing, is that it's always been there. It's always been there, and it's always something that we talk about. Yeah, there's a mental health person, but is it really a true mental health diagnosis, or is it PTSD that's related to the addiction itself? And I think that many times they're getting labels from psychiatry of bipolar disorder or some other disorder, schizophrenia, because that was a fun thing to do for a long time for many people, when in reality these people have severe trauma and it's PTSD. And is there PTSD as a result of the lifestyle that you live? Because if you're selling yourself, if you're doing whatever, if you've been attacked, if you've been in violent situations, and that's all a part of most addicts, not a lot of addicts' lives, that they're exposed to a lot of trauma just as a byproduct of the lifestyle that you live.
Hi there. So in addition to doing outpatient MAT, I also work with the emergency psych team with UH, and it was really exciting to hear you talking about being such an advocate for substance use in the emergency room. I found that psych and substance use tend to be kind of gray areas, and a lot of the emergency physicians tend to be really protocol and algorithm driven, and so it's often difficult to kind of shift the culture there. What were your experiences in the emergency room, and do you have any tips on how to kind of shift that culture?
I think one of the most important things is having an advocate, someone who's going to really sort of take the reins and start it. So if you don't have that, I would work on that first. We were really lucky in our emergency department. The chairman of my department is amazing. He not only supported us with Project Dawn and everything, he actually went out and got his addiction fellowship training, and he's led the effort to get an addiction consult service for the hospital and the fellowship and everything. It's just, he's amazing. So good leadership is key. We also applied for an Ohio Mental Health and Addiction Services case management grant. It's a really small grant. It's like $50,000. We use that to hire a nurse practitioner who is also a case manager. And she's only 50% time. And we started with her getting her X waiver and not seeing the patients independently, but helping the providers. So she would essentially scan our track board, look and see if there was somebody who was an appropriate candidate for MAT, and then just take the ball and, run with it. Let the doctor know, hey, we think this is a good candidate for MAT. We'd like to talk with them. As long as you're okay with us doing this, we'll do everything. She'll order the labs. If there was prior auth, which has mostly gone away now. Thank you. She would do that. She would schedule the appointment for them, make sure they had a peer supporter, and really just kind of make it as easy for the ED doc as possible. That's going to be your biggest resistance, is they're so busy, and the culture has been for decades, that's the easiest patient to take care of, right? I gave them Narcan and then they're gone, right? But now we're asking those same doctors to make this one of their most high need patients that's going to be in the emergency department for hours and hours. And the only way to convince them is to make it easy for them.
Just one more question, I think, here.
Thank you so much for the presentation. My question is surrounding the topic of the social determinants of health. That has been something lately that they said if addressed alongside the addiction may have better outcomes. Is any of your hospitals, the clinic or Metro, actually doing work that addresses things like food insecurity, housing, transportation, alongside giving treatment?
I can talk a little bit about it, and I think Chris probably can as well. For our population, and actually it's not just for our patients with addiction, we have a lift contract that is available to patients throughout the system. We use it in our programs to connect people to their MAT appointments. So, when we see them in the emergency department, we will schedule a lift ride for them, home, but also from their addiction appointment to back and forth to home. And so that's one of the things that's really made our program successful, especially our jail program, because the biggest barrier really for getting to treatment is transportation primarily. We do have in the jail, we have a program to help connect people to job training as well. I know we have a social determinants of health council that addresses some of these on a more widespread scale. Chris, I don't know if you're more familiar with some of those other, like the food insecurity and
Right. So
other.
Metro Health is it's the safety net hospital or essential hospital, depending on what terms you want to use. So we've always had lots of programs around transportation and trying to help people with the social determinants of health. Recently, we've opened the Institute for Hope, and part of that is actually trying to embed social determinants of health into the electronic medical record so that you can more easily sort of figure out what people's needs are and address those needs. We've started programs like having the food bank actually come into Metro, and you can, as a provider for certain patients, unfortunately not for everybody, but for certain patients, you can write a food prescription. And as Joan mentioned, we have transportation available. And as Jennifer sort of alluded to, there's hopefully a housing initiative coming. So, but I think the Institute for Hope is really the big thing that we've been doing, is to try to actually take the different ways that we address the social determinants of health and put it into the medical record so you can kind of scale it so it's not just a one-off where you're sort of handing somebody a social work referral, but you're actually, as a system, trying to help neighborhoods.
Thank you so much. I'm sorry that I have to cut it short again. I know there's other questions, but I want to give you, at least 5 minutes or more to just stretch and use the restroom if you need to before our next speaker begins. And that will be our final speaker of the day. Thank you.